Welcome. Thank you for attending the 2020 Behavioral Health Symposium. We are happy to host this event as a virtual conference because we care about your health and safety. But we also understand how important it is to provide relevant, robust, continuing education to Louisiana healthcare professionals. For quality purposes, all participants will be muted during the presentation. If you would like to submit a question to the speaker, please use the Q&A feature in the virtual platform. Accreditation. This session is accredited for 1.25 hours for the following: social workers, clinical, peer support specialists, psychologists, nursing contact hours, AMA PRA Category 1 credit, and LPC professional counselors is pending. Full participation is required to receive credit and will be monitored throughout the session. You will receive an email from Women's Foundation with detailed instructions on how to claim your credits and access your certificates. Additional information is available in the digital event booklet. Toni Bankston has no financial disclosures. None of the members of the Symposium Planning Committee or any session moderators have any financial disclosures. This session is entitled Transforming Trauma. Our speaker this afternoon is Toni Bankston, MSW, who is the Chief Executive Officer of the Baton Rouge Children's Advocacy Center and clinical lead of the Center of Mind-Body Medicine Puerto Rico Community Wellness Program. She also consults with CMBM by bringing her 30 years of experience in the design and execution of trauma programs, particularly those targeting children and families, to build trauma training for children and their providers. Toni serves as a member of the senior faculty of Center for Mind-Body Medicine and Global Trauma Relief Team in the programs of Haiti, Israel, and Gaza. She has worked with high school students and teachers in Parkland, Florida, in the aftermath of the massacre of the Stoneman Douglas High School in the Cumberland, Maryland, in response to the opioid crisis. In her local community, Toni also serves as a Master ACE Adverse Children Experiences Trainer for the state of Louisiana, the Louisiana Governor's Children Cabinet Advisory Board, and the Governor's Advisory Board for Human Trafficking. Her work in Baton Rouge has included developing and leading wellness programs for the homeless, disaster impacted, and children in urban school-based settings. She also trains educators, law enforcement officers, judges, and community service professionals in building trauma-responsive teams and systems, helping them mitigate the effects of secondary stress and vicarious trauma. In collaboration with the Baton Rouge Mayor's Office, she consults and provides leadership to other organizations towards the aim of developing a more trauma-informed city of Baton Rouge. She was honored recently by the National Association of Social Workers, Louisiana chapter, for her local work with the Social Worker of the Year Award for the state of Louisiana. Without further ado, I give you Toni Bankston.
Thank you, Jackie. I actually got to know Jackie when I was working with homeless folks in Baton Rouge. Jackie is yet another one of those people that we are fortunate to have in our state who really have the heart for working with people who are disadvantaged, and it's just really great to have her introduce me this morning. I'd like to also thank the Women's Foundation for honoring me for being here today, and the Office of Behavioral Health. Lots of colleagues there who I highly respect and have worked really hand in hand with in different types of trauma. As many of you know who are listening and watching, Louisiana and Baton Rouge in particular are no strangers to trauma. We've had lots of community-wide trauma, lots of disaster, and one of the reasons that I have chosen to stay here and live here my whole life where I was born is that I love our people. We're so resilient. And I really feel that there's so much that I'm bringing to other places in the United States and around the world from my experiences of being with our Louisiana people and what they do and how they survive and how they thrive under the most challenging circumstances. So bringing our story to other people in other places, and then also bringing the story of other people in other places to here in Louisiana and in Baton Rouge, because at the end of the day, we are all connected. I'm going to talk in a little bit about the importance of connection in transforming from trauma. Connection and relationship is one of the most important factors in coming back after trauma. I want to tell you a couple of little caveats for my presentation today. I have way more slides than I have time to share with you, so please bear with me as I move through some of them kind of quickly. Also, as Jackie mentioned, I did do some work with homeless folks, but the primary focus of my work over the years has been children and families. So you're going to hear me talk a lot about children and how trauma impacts children and what we can do to help them. But I want to say that it's really important, even if you don't work with children, your population is adults, your population is folks who are dealing with addiction, to understand the importance of having that baseline knowledge of working with children or what children go through related to trauma. Because what we know from research, and we're going to visit this in a moment, is that those children who are impacted by trauma who don't recover are much more likely to be those folks that we now talk about who are human trafficking victims, they're more likely to have an addiction. They're more likely to be homeless. So even if your population is an adult population that you're working with, it really behooves everyone to have a general working knowledge about childhood trauma. So you'll hear me talk about that quite a bit. The transformation piece of this transforming trauma discussion will be kind of interwoven throughout. I only have an hour and 15 minutes with all of you, so I'll try to insert some of the ways that we actually work with trauma as I'm discussing the components of trauma with you. And that's really, I think, the best way for me to tackle a very big topic that we could talk about all day in just the short time that we have together. So with that, I will start off with our first slide. I want to make sure you're seeing it. I really love this quote. Found this quote when I was presenting some work with the Department of Education. And you'll see that this is a quote from the School Justice Partnership. Few events outside the classroom have as profound an impact on multiple domains of student development as traumatic life experiences. What I really like about this quote is that it's capturing some really important fundamental information about trauma. And that is that there are so many things that children, but I would also argue adults, bring to different settings in which we're encountering them. Children, for example, in schools can bring in, they have medical issues, they have challenges in their family, they have challenges with poverty, they have challenges with parental incarceration. Adults you're encountering in adult settings have their own set of variables that they're presenting with, the set of challenges. But what this quote is implying is that when we seek to really focus our sights on trauma and making a difference with trauma, we're actually casting the widest net that we can cast with both children and adults, I would argue, because trauma is that indicator, trauma is that phenomenon that really runs across all of those challenges. It's the common denominator of all of those things. So recently what we're seeing with our city in Baton Rouge and with our schools is because we're becoming more trauma informed, the schools and the city across law enforcement and others, we have a mayor who's really progressive about understanding trauma and helping Baton Rouge to become more informed about trauma. The reason for that is because these folks recognize now that that's the way we really get to the heart of a lot of issues, because it's a common denominator across a lot of social problems, a lot of mental health problems, and actually a common denominator across and a contributor to physical health problems as well. When I'm talking to people about trauma, and actually I would talk just this way I'm talking to you today with a group of young people, one of the ways we help transform trauma when we're working with young populations is to begin even at a young age to help children understand the biology of stress, to understand how stress, or at a higher level, which then becomes trauma, how that impacts their body, how that impacts their mind. And the other thing that can be really powerful in that step of transforming trauma is helping kids to understand that not only can they understand, even at a very young age, how their mind works and their body works, but that once they do, they can actually do some very simple things to help themselves. A 5-year-old can learn breath work, for example, to help calm down the nervous system. So we start the conversation by talking about some of the fundamental biological processes and neurological processes that are happening when we are under stress, particularly chronic stress, and also trauma. There's a quote here by Dr. James Gordon in his book Unstuck. He's written several books. The most recent one is Trauma and Transformation. Dr. Gordon talks about how human beings are very much like animals in the wild. We, like animals in the wild, we all have sort of this internal emergency response system. When I'm talking to kiddos, I'll say, you know, you have your own built-in 911 system. And your body is so smart that it knows that when you're encountering a threat or something scary, you don't even have to think to help yourself. Your body is designed to sense that through all the sensory processes and just move out of the way, either run to get away or stand and defend yourself. And we call that the fight or flight response. So even young kids can learn about this. Now, what happens with adults, though? So in our picture here, let's talk about our picture. In our picture, we have this little antelope who's being chased by the lion. Obviously, his emergency response system has been engaged, and he's running. He's trying to get out of town, right? Well, because I'm very optimistic, I tend to be a little bit of a Pollyanna. I always want to believe that this little antelope tripped over the rock. I mean, the lion tripped over the rock, the antelope got away and was able to live another day because he avoided the threat. And so when we think about this very basic dynamic here, what we know about animals is that once the threat is gone, once the lion is gone, what do? Well, they go back to their life. They go back to eating and grazing. They might shake off the stress a little bit, but they go back to eating and grazing and playing with their siblings, their parents. And the lion is literally out of sight, out of mind. And that's because obviously animals have a smaller brain than adults do. With adults, however, because we have this bigger brain, because we have this thing called memory, we actually may stay engaged in a fight or flight process much longer than animals. And that's because as long as we can remember or think about an image or an event that happened, even if it happened 5 years ago, our body will respond exactly the same way. That emergency response system will kick in just as if the event were happening today and now. So in a sense, as Dr. Gordon says here, for adults, unlike the antelope, it's as though we're carrying our lions with us. So when we're encountering children in the schools or encountering adults in a homeless setting, for example, it's important to understand, if you're trauma informed, that you're looking at an individual who may be carrying a lion with them. Think about our law enforcement officers who go out to a scene, and this person is still really in a state of fight or flight from chronic stress or trauma. You know, they're in a mode that it's a survival mode. And when that happens, there's not, the executive functioning goes offline, and we're not really making a lot of rational choices. So if we can understand across all disciplines, including mental health professionals, but not limited to mental health professionals, that we can actually engage with people in a way that helps them to calm their nervous systems, then we're less likely to actually escalate a stress response that's already taking place. And this is really key and fundamental, and this is why I'm spending a lot of time on this. Let's just review some trauma basics real quickly. I'm sort of going in with the understanding that a lot of the folks that are listening to this presentation have a lot of knowledge and wisdom about trauma and probably are working in it every day, particularly as we are in the middle of a pandemic right now. You're really working with people with many levels of trauma. And we're also doing hurricane disaster work. Unfortunately, it was a terrible storm, Laura. So I want to just cover a few basics, though, just so that we're all kind of on the same page as we go a little further. Here, there are two definitions here. The first one is the SAMHSA definition that everyone knows about. It's a nice, more sophisticated definition, but the one that I always come back to is the second definition. And this definition was given to me in a group by a local teenager who was homeless. She had been surviving trauma, working on her trauma in the group, and she says, trauma is like drama without the D, except drama is something you ask for, and trauma is something you didn't ask for. it's something that just happened to you. And one of the things that I think she's really eloquently capturing here is that common denominator, that common thing that we find in all survivors of trauma, which is really losing a sense of control, losing a sense of mastery. It's like really having the rug pulled out from underneath you. And so what happens is that we become dysregulated. And so one of the important things when I think about transforming that particular part of trauma, a big focus for us in responding to trauma and helping people to recover from trauma is right away teaching them skills that help them to become regulated, that help them to kind of have a sense of mastery. So we want to use approaches that are empowering, that kind of reduce shame. And so we don't want them to wait, for example, 14 sessions to get to the end of their narrative work to feel relief. We want them to feel relief in the first session. And the way to do that is to infuse our approaches with skills. In our case, in our work around the world, it really has been teaching people the skills of mind-body medicine while being in a group and connecting with other people who are experiencing a similar trauma. That's really key for us. But because of that, this work can be integrated in many other modalities, such as EMDR or trauma-focused cognitive behavioral therapy. At the Baton Rouge Children's Advocacy Center, we do all of those things because we actually are required and mandated to do those things. But those approaches are heavily integrated with skills that people can learn right away to feel a little bit more control of their life again and to be able to regulate themselves. Quickly, another great quote that I like. So Dr. Bessel van der Kolk was one of the pioneers one of many, but one of the big ones who really began to push us to thinking beyond one lens of looking at trauma. And mainly what he invited us to look at, he has a book that he wrote called The Body Keeps the Score. He really pushes us to think about the impact of trauma as not just something that's affecting the mind, but something that affects the mind, the brain, and the body. And oftentimes the cues about trauma or the wounds of trauma are actually felt and experienced first in the body. When people come to your practice or they come to your setting, they often are not able to really talk about what's happened to them. And so sometimes what we do is we use other methods to really help them get regulated first. Yoga is one example. We do shaking, we do movement with our kiddos. And that's so that they can finally get to a place where when they're ready, they can begin to put words to what happened. But a lot of times people need expressive techniques to get there first. So his quote is, trauma is not just an event that took place sometime in the past, it is also the imprint left by that experience on mind, brain, and body. And I would take it one step further and say, and it also affects spirit as well. Spirituality, existential crises occur in the aftermath of trauma. And sometimes it actually has the opposite effect of actually strengthening our spirituality or strengthening our faith. But that's another important point. And what it really does suggest is that whatever modality we use, it needs to be very comprehensive. It cannot just have a singular focus. We need to have, put very plainly, we need to have a lot of tools in our toolkit if we're going to work with people who've been traumatized. And so where does it come from? Well, you know these things as well as I do, that we keep broadening this list because unfortunately in today's society, there are many sources of trauma. Here's one list on this first page, and then the second list. Unfortunately, we had to amend the list to include school violence because we saw an uptick in that. One of the things I'll mention that's really very recent is we work at the Baton Rouge Children's Advocacy Center. Our focus is children who've been impacted by violent crime. So one of the things that we have already documented is that during this pandemic that we are responding to and experiencing, our child abuse reports have gone up. We've had more instances of child abuse as children are isolated from the place, which are schools, where they often do the first reporting of those events that happen to them. Unfortunately, not all children are safe at home. And so as a result of a pandemic, we have children who've been isolated at home And then at the same time that's happening, we have parents, family members who are deeply stressed on so many levels: grief, loss, financial concerns, job loss, you name it. And that is really like a perfect storm that really makes families more at risk for domestic violence and child abuse. And we recently have seen a significant increase in that. So that's one of the things I think that I would add to this list if I had time to revise the slide before today. Another great quote, Bruce Perry, another pioneer, another physician, done a lot of work with early childhood trauma. I won't read through this quote. You can read it on your own. But the really important teaching point here of this quote is to really understand that when you're working with trauma in childhood and you're working with trauma in adulthood, they are very different, qualitatively very different work. Working with children, this is more of a longitudinal effect. So something happens to a 5-year-old, he's probably going to be revisiting it at 10. We also know that if something happens at 5, it can change the architecture of the brain. So it's not just a one and done deal. We're really talking about a long-term effect, and that the treatment approach may take longer than in adulthood. With adult trauma, adults come in and oftentimes there's been a singular event. And so we're kind of working with that event, and then we deal with that event, and then it's resolved. With children, we're more likely to be dealing with cluster of trauma. More often than not, when children come to the CAC, they're coming because of one allegation of trauma, such as sexual abuse. But as we go in and assess the family, we do our screenings of our kids, we find out that actually there are multiple things going on that the child is facing. Some fundamental principles that I like to keep in mind in working with trauma. I won't read through all of them, but I'm going to highlight a couple because I know you're going to have these slides available to you later. We're going to talk a little bit today about the ACE study and how it taught us that trauma is prevalent. When I was in training back in the 80s, we were taught that, PTSD was sort of like a reaction to an event that was considered rare. We've completely flipped our script on that. We've completely come to understand that actually most people in their lifetime at some point will experience trauma. So rather than thinking of an oddity, of thinking of trauma as something as an oddity, it's actually something that is pretty common. And also, again, as I said before, it occurs in clusters. We know that children and teens are more vulnerable. Their brains are still in a state of development. So they, obviously they are more vulnerable. And this last point that says that every child's response to trauma is different depending on different variables, which then goes into the next point, which implies that there really is no one size fits all response to childhood trauma. Every child, if you think about it, you work with kids or you have children, you know that there's I have 4 children, they're all very unique, and every child has a different window. Some children may want to use art and expression to really address their trauma. Some children are actually quite verbal. We have cops that show up to scenes at 3 o'clock in the morning of a childhood trauma, and the child is just gabbing and telling everything that happened detail by detail. One of the teaching points with that for us working with law enforcement is to help them recognize they're really excited because they're getting all the details, but it probably isn't healthy for the child to be spouting all that off because, the brain is really engaged and traumatized, and, that can be re-traumatizing. But the point I'm making is that some kids are verbal, some are not. Some really have to use their bodies to really heal the wounds of trauma. And as we're going to talk about, there's a profound impact on child development from trauma that lasts the entire lifespan. That's the bad news. The good news is that we can also have a very positive, profound impact if we're able to get trauma early. One of the most poignant examples of that, probably more today so than last week if I were doing this talk, we happen to have been dealing with, unfortunately, a couple of kidnappings, that led to sexual trauma of our children here in this city. Our perpetrators have used this pandemic to really gain access to children in a way that they haven't before, at a level that they haven't before, using social media, using even gaming to gain access to children. And so with these kinds of situations, we have to be very vigilant, and we have to understand that this is occurring, that it's common, that it's not something that's rare. And actually, I'm going to come back to that in a moment, to that example. So not all children develop PTSD. Back in the day, we used to really look for that PTSD diagnosis. That was sort of the key that unlocked the door for the treatment of trauma. What we understand now, though, is that there are many people who are impacted by trauma, whether their symptoms rise to the level of PTSD or not. And what this is indicating is that we need to consider the medical model of working with trauma, but we also need to think beyond it. It also says that because people can have a lot of impact from trauma, whether they rise to the level of PTSD or not, that there are going to be many more people that are impacted, and those numbers are going to supersede the ability of mental health professionals to address it alone. And what this indicates is that many people in many disciplines need to understand trauma. I'm not suggesting that people that are non-clinicians or non-mental health professionals are going around doing therapy. What I'm saying is that there are many things that can be done to mitigate trauma, even if one is not a mental health professional. And so we're becoming more inclusive in the folks that are responding to trauma. And because of that, we're broadening and widening our training programs to include people that are not just mental health professionals, not just medical professionals, but people across all disciplines. And here's a listing of the way that all the many different ways that trauma impacts our young people. And you'll see there are similar crossover symptoms in our adults as well. One of the things I point out about this is I ask you to just kind of look at these symptoms and notice how there are many things on this list that actually look like other things. So if I were a clinician looking at number 2, for example, and I am a trained clinician, I might say, well, I probably need to rule out a bipolar disorder. I need to rule out a mood disorder. What this is really saying is that, trauma can be tricky. Trauma can often be misdiagnosed. We see a lot of kids who are diagnosed as ADHD in schools, or having a mood disorder or an anxiety disorder, when really what's happening is underneath those behaviors and underneath those symptoms is the occurrence of trauma that has not yet been identified or recognized or treated. So that really needs to be part of the equation more and more as we understand the prevalence of trauma. And of course, there are other cognitive changes that we're aware of that happen with trauma, or happen even with chronic stress. One of the things I talk a lot when I'm talking with teachers in helping teachers to recognize trauma when it shows up in their classroom is to notice that one of the most common cognitive errors, if you would, that occur when someone is experiencing trauma is that they misread facial expressions. If they are in a fight or flight kind of response mode, they're looking for threat. They are looking for threat around every corner. And that includes misinterpreting the cues of a person who's looking at them. So for example, a teacher may walk over to a student and have just a very kind of innocent look of concern at the student, but the student can interpret that look as she's about to get me. So I've got to do a preemptive strike. I've got to get in her face and I've got to start an argument before she comes after me. So it's really understanding that this is all about the brain. This is all about the nervous system. There's trauma bonding. I won't go into these much, but often children, there's so much misunderstanding about how children respond to trauma, why it takes children 2 years, for example, to report. Oftentimes when we get these cases, the event has happened months or years even before it actually comes to our CAC. And that's often here because either they've been threatened, or in many cases, the person who did the trauma perpetration is also the person that they trust the most, is often the person who is the most positive person in their life. Now, it's coming from a place of manipulation and grooming, but kids don't know that. So it makes it's another way that trauma can be challenging even to identify in the first place because of this idealization. I've worked with victims where had to work with them for 9 months before they can even recognize that they're a victim in the first place, because they're holding on to the idea that this was my boyfriend, he loves me, I love him. And so it takes a long time, a lot of persistence and a lot of patience, a lot of meeting people where they are versus coming at people from these prescriptive methods, like, trying to preach to somebody. That's really not going to work. It's really having to stay for the long game with folks. And then there's triggers and flashbacks, as we all know, are very common with trauma. When I'm working with people who obviously have triggers and flashbacks as an important common part of their challenge, I actually have understood now that I kind of welcome that in if it comes up in a group. I used to fear that. Well, what if somebody gets triggered? Well, now I kind of have a different understanding of that because of the mind-body toolkit that I bring with me, that if that trigger shows up, we have an incredible opportunity to do something different with that, to help people understand that they can ride the wave of that trigger and they can use the skills to calm themselves. It's so empowering. So it's something that, rather than in a treatment setting fearing for that to come up, to really understand that if it does, it creates a wonderful opportunity for teaching and learning. A few more facts about PTSD, and I'm really going to run through these very quickly. Here's some of the mixed picture of PTSD. So again, can be really tricky to identify. There are so many things across the board that fit with trauma and with PTSD. You have some people who are agitated and they want to fight. Other people are more passive and they're withdrawn into their room. They may be in fight, they may be in flight, they may be in freezing mode. This is something that's been more understood and studied in recent years, the freeze response. Or they may be actually using all three, going in and out of all three responses. Again, it's a survival instinct. Kind of talked about this already. Diagnosis is useful, but it can also be limiting, that if we're really coming out of a lens of what is the diagnosis and that's all we're thinking about, we're going to miss some things. And we're also going to miss people who are greatly impacted, but yet don't rise to the level of a diagnostic code. We also know that people who've experienced amnesia or dissociation are much more likely to develop and have ongoing PTSD. We also know that some people are more susceptible to PTSD, but it's important to regard PTSD really at the end of the day, it is a normal response to an utterly abnormal situation, which can be very normalizing and empowering to share with clients. And we also know that large-scale PTSD is becoming more and more a part of our life. And actually, we had this slide at the Center for Mind-Body Medicine before the pandemic. And to me, when we think about this point in the view of our current pandemic, it really brings it to life. Just some more facts about trauma that I haven't talked about already. Some I have, so I'll kind of highlight the ones that I haven't. But, when you have an event like a pandemic, or you have a traumatic death of someone in your life, you notice that you do sort of this kind of reevaluation of where you are, really looking at your life, your death, the meaning. All people who are recovering from trauma at some point, part of the healing journey is to help them find meaning. They want to find a meaning in the aftermath of something so terrible. And this is one reason why we have so many people in the CAC world, for example, probably more people than not who come to work for children's advocacy centers were victims, because they understand firsthand what it was like. And while they may have really done a lot of work and recovery in their own trauma, they're in this last phase of their healing where they want to bring this work, they want to help other people. So it's important to understand that when you're working with people of trauma, what are some ways you can help them find meaning with something that happened that was so terrible? How prevalent is trauma? I always want to include this slide in children of color because we need to really be honest about that when we're working particularly with young people, that children of color are 3 times more likely, for example, to be a victim of robbery, and look at this, 5 times more likely to be victims of homicide. So if we're going to have a trauma-informed program, or we're going to have a trauma-informed city, or we're going to have a trauma-informed school, we need to make sure that we are covering our persons of color, that we are looking at people across. We're not only are we being inclusive and highlighting people who are most at risk, which includes people of color, but the other thing I'll mention in the transforming part of trauma is part of transforming trauma is actually honoring culture. So when I was recently working with training with people from a Native American, a First Nation in Minnesota. And one of the things that we were talking about is looking at the family genogram, looking at the family history to see where the clues are there of people who have been through difficult things before and how they have survived and how they have been resilient. And it's a similar thing of looking at, historical trauma of our Black colleagues and friends and family, that really helping people look at the history, look at understanding the history, that this is generational, that something, we know this now through science, that something that happened hundreds of years ago can still impact the mind and body, even the DNA. So when we're talking about trauma and addressing trauma, it's understanding that some people are more at risk than others, but it's also understanding that heritage, culture, ethnicity, all of that needs to be honored when we are going to work with people. And actually, we want to highlight and bring in the practices of those cultures that are they're already using these practices that work for them. So that needs to be kind of a part of the treatment plan as well. More stats on trauma, 82%. Again, we're going away from an oddity and moving toward really more of this is a common occurrence. 37% are more likely to have other conditions along with PTSD. Here's some local stats. Again, I'm going to move through these very quickly. These are local children. There were 280 kids that we screened during a quarter. And if you notice, these were all of the things that that were validated that they had experienced. And again, it wasn't just one allegation, but it was really a cluster of things that happened to them. The other trend that we see when we look at children is that oftentimes children, here's the percentage of children who were actually at what we consider a clinical cutoff for trauma. You see the graph here that shows both children and teenagers, their ages are down at the bottom, 0 to 6, 7 to 12, and 13 to 18. We screened both the children and the caregivers to report on this. One of the things that we realized in looking at this is oftentimes the children or the teens actually had a higher appraisal of what had happened to them than their parents. And what did that mean to us? Didn't mean that our parents or adults were not good parents or that they didn't care. It was really the idea that adults often underestimate what children experience and the extent of their reactions. And I think this is true for a number of reasons. Number one, more adults who bring in children who've been traumatized were traumatized themselves. So for them, it's like, well, this happened to me and I got through it, so we're just going to move on from this. That's one thing we see. But the other thing that we see is that children are really great, even though they're young, they're really great at not telling their parents things. They're really great at keeping things from their parents because they don't want to upset their parents. Can't tell you how many times a parent will say, well, how come they told the school guidance counselor? I've always talked to my daughter. Why did they tell her first? But it's because, honestly, they want to protect the parent from those emotions. And sometimes they have fears about what the parent is going to do if they hear about the trauma. So there's a lot of reasons, but this is a parent. So if you're working with kids, part of what you're doing is you're sort of helping the parent to wake up also to the reality of what's happened, and you have to work with their vicarious trauma. And sometimes you're actually working with their own trauma from their own childhood as well that's never been revealed. I'm going to go quickly through this one, the trauma-informed movement. I know people are hearing that thrown around a lot. I'm really glad it's being thrown around a lot because I think it's so important to understand trauma for all the reasons I've already mentioned. But if you're going to talk about how we began to do that and how we began to be interested in being trauma-informed, you want to talk about the ACE study. ACEs, for those of you who may not be aware, stands for Adverse Childhood Experiences. I was actually trained by Dr. Anda. He came and trained several cohorts here in Louisiana of bringing the knowledge of the ACE study to people across our state. I was in the first cohort, but interestingly, I went back to hear Dr. Anda speak just a couple of months ago, and he said something interesting that I didn't know. He said, you know, we were sitting around in a cafeteria trying to figure out what we were going to call this study. We knew that the study was about childhood trauma and how it affects you the rest of your life, but we couldn't think of what we were going to call it. So we thought of, he said, all we knew was we really wanted it to have the ACE acronym. And so we came up with adverse childhood experiences. But if you think about it, the study is basically about trauma. And initially, this study involved 17,000 participants, mostly white, mostly middle class, well-educated. Why that's important is because the findings were that even in that seemingly well-educated, seemingly lower risk population, ACEs or childhood trauma were common, and that was something that was not expected. I'm going to flip through the brain talk in the interest of time. What ACEs told us is that trauma, one of the huge findings of ACEs, and this has been supported in continuous follow-up studies on ACEs now in many different types of populations, many types of socioeconomic situations, culture, ethnicity, is that trauma has a way of predicting things that happen in adult that are bad. This little diagram that you're seeing right here is one of my favorites. It's one of the things that the ACEs coalition uses to explain what happens to kids. And they really oversimplify the point to make a point by saying that if you think about trauma in childhood, it's like you have two groups of children. We know that there are a lot more different groups than that, but we're gonna boil it down to two groups. You have one child who's growing up in a world of danger, never knows where the next threat is coming from. This child, we talked about fight, flight, or freeze response, that emergency response. Well, and many of our children who are growing up in community violence, witnessing domestic violence, sexual trauma, all of those things, they are often remaining in fight, flight, or freeze. So it's almost like there's a switch that gets turned on and never gets turned off, right? Well, I want to just mention this, that if you remember what we talked about earlier about the antelope and the lion, the antelope goes back to calm and cool, and the adult stays in that trauma mode, that fight or flight mode. The reason that that's not a good thing is because those mechanisms are really designed to only stay in place for about 20 minutes at the most. All of those hormones, adrenaline, cortisol, insulin, all of those things that the body uses in a time of response of an emergency are very helpful when we're trying to survive an emergency. But when those things are floating around beyond that 20-minute point, they actually become harmful. And that's what you think of when you think of those words, toxic stress. So here we have this child. He's, his switch never gets turned off, or maybe it's off and on every day. So he's in a situation of toxic stress. This child, his brain is being wired to survive the worst of circumstances. So his mind and body are adapting to live in the world that he's encountering. On the other hand, we have this other kid who's growing up in a world of safety. Things are predictable, there's routine. Very rarely does anything bad happen. If it does, he falls down, somebody picks him up, wipes him off, and he goes about his play. Because of this safety and this routine and this structure and predictability, this child has the luxury of focusing on people. He's like a little sponge. He's learning everything. He can focus on all kinds of possibilities. This child, unlike the child in the previous world, his brain, his body is designed or is actually adapting to survive the best of circumstances. Both children are adapting. Neither one is better or worse than the other, right? The old way we used to look at this is that the child at the top was not normal. The child at the top this was what we used to call an abnormal adaptation. We've completely come around the corner from that way of thinking, and what we know now is that actually that's not true. Both children are adapting to the environments that they're being brought up in. So what happens when you take a kid who's been growing up in this world of danger and you put him in a school and you say, I want you to sit here. I want you to sit quietly. I want you to hear everything the teacher says. And I want you to get along with all of your friends. And I want you to do math problems. Remember what we said about fight or flight, the executive functioning goes offline? So the problem happens that we put children who've grown up in these kinds of circumstances and we place them in situations where they're not adapted to survive in those situations. And so they have issues. That's where the problems come in. When those adaptations collide with the expectations of these other settings. So I'm gonna go back to this previous slide. In some ways, if you think about the kid who's growing up in the dangerous environment, think about the kind of professions where that kid really actually has some prerequisites for being on the job, because this child is no stranger to danger, okay? On the other hand, if we took a child who grew up in a world of safety and we said, okay, we're gonna ship you off to Afghanistan and you're gonna be in battle and that's that. We don't do that, right? What do? We train people because we understand that they've been living here in a world, mostly in a world of safety, and they don't know how to work in a war zone. They have to be trained. So just as those kids, those 18-year-olds have to be trained to be able to adapt to a war zone, children who grow up in a world of danger and uncertainty, they also have to have training to be able to perform in a school setting, because it's a completely different world to them and they're dysregulated. So how can they learn if they're not regulated? So that's really the big shift that we're seeing, is understanding that it's not looking at labels and pathology and calling kids bad kids. It's understanding that that kid's behavior in his world represents some kind of survival for him. So ACEs went on to, there was the initial study, but then it went on to say, I wonder how big this is. If in this first study, ACEs were so common and was so connected to issues in health and mental health, we wonder if this is a larger phenomenon. So that's how the ACE study began to grow. And they really began to look at childhood trauma, not just from, say, the lens of child abuse or the lens of mental health, but we began to look at it more through the lens of public health. This is a public health problem that we have to address because there are far-reaching outcomes. And what the ACEs study did, you know, when we talk about ACEs, people get kind of depressed because they feel like, well, you know, all the news about ACEs is bad. But the reason why this knowledge is so important is that it gives us a choice to understand that if we understand ACEs and we know where those risks are leading, we can actually change things, because what we can predict, we can prevent. Just going to share real quickly these are just some of the basics of the ACE study. I really whittled it down to the most important pieces. This is what the original ACEs study looked like. This is what they actually did study. They looked at all of these issues, and for each issue that a person had experienced, they would give themselves a 1. So if you as a child experienced parental incarceration, you would get 1 point for that. Even if you had 3 or 4 people in your family that were incarcerated, you only got 1 point. If you witnessed your mom being abused, it didn't matter how often you experienced it, you got a score of 1 for that particular piece. So ultimately, there were 10 things that they studied. It's been greatly increased since then. This is the original study, but the total number of ACEs that you could have is 10, all the way from 0 to 10. And what they found is that even in this very well cared for group of educated people that ACEs were common, you'll see there that only 33% of this whole group had 0 ACEs. The rest had at least 1. And what they also found is that it's sort of like putting gas in your car. The more gas you put in your car, the farther you can go. With the ACEs study, the more ACEs you had, the more likely you were to have health problems later. So you'll see on this graph from 0 all the way to 5. And then as the ACEs go up, so do the health problems. I could show you so many graphs for so many different health problems. We don't have time for that today. But basically, they all look like this, whether we're talking about lung disease, obesity, diabetes. The more ACEs you have, the more likely you are to have all kinds of problems. I think I have a couple. Yeah, here's one example. of smoking and lung disease and the relationship between the number of ACEs you have and the likelihood that you are to develop these issues. Real quickly, the other thing that this taught us was that educating people alone, because we now understand that there's a correlation between ACEs and smoking, for example, that just telling people smoking is bad for you is not going to get people to stop smoking. And that's because when you think about smoking, if you're, because of ACEs, more likely to start smoking at the age of 11 to 13, you're doing that to find a way to calm your nerves from the trauma that you're experiencing. So if it becomes habitual, and then unfortunately with some folks, it leads to other types of drugs, because again, you're seeking to regulate the nervous system that's been impacted by the trauma. And this kind of gives us some information about why all of those public health education campaigns in the 80s about this is your brain on drugs and smoking is bad for you, don't do it. Just education alone is not enough. If we're going to ask people not to smoke or not to use drugs, we need to understand that there's such a huge connection between trauma and that behavior, that we have to heal the trauma. We have to help people find ways to regulate their behavior. Here's just another example of ACEs and depression. And this is it's not an exhaustive list of all of the things that have been attributed to ACEs. Look at that. It's across both the physical and mental health sectors. One of the things the ACEs study also told us, you heard me talk about this a lot, that if you have one ACE, you're actually 87% more likely to have a second ACE. ACEs are also generational. If you have a parent who has a high ACE score, you're more likely to have, their child is more likely also to have a high ACE score. And this is just a little population attributable risk slide. This is a slide that public health folks use to kind of illustrate public health issues. So if you look around the wheel there, you'll notice all those different problems we just talked about. In the middle of the wheel, you'll see this big oil slick. The oil slick represents ACEs. So the oil slick, the percentage inside the oil slick represents how much of that problem would go away overnight if we could just get rid of childhood trauma. If we could get rid of ACEs, wave a magic wand, ACEs are gone. What that means is that overnight, 52% of disability would go away, 55% of anxiety, 67% of suicide. And again, the good news is that while this is bad news, it's good news in the sense that ACEs are not destiny. Because just as we've learned a lot about what contributes to problems in adulthood that generate from early childhood adversity, we also know that there's a science of resilience. We've also learned a lot about what makes one child or even adult more resilient than the other. What are the factors that need to happen in order for people to transform trauma? So I'm going to spend the next few minutes talking very broad stroke about transforming trauma and what are the factors that need to be present. So when the ACEs teams began to look at resilience, we've talked a lot actually about early childhood trauma and how it impacts children and how it impacts the entire lifespan, how it actually changes the architecture of the brain. But the ACEs teams also looked at what are the factors for the people that do well. All of you know, I know I've experienced kids that we've worked with or adults that we've worked with where we've said, because of everything this person went through in their life, it just doesn't make sense that they're doing so well. How are they making A's? How are they having so many great relationships and friendships? How is it that some of our leaders in our country and our community were themselves survivors of trauma? What were the factors that were present that really shifted that script? Part of it can be the healing process, obviously, having resources, having access to care. Yes, that's true. But the overarching three factors that have been really associated with long-term recovery and resilience in the aftermath of trauma are here in front of you. And they are three spheres that are actually nested with one another. one thing to think about before I mention these is that it's not enough to have one of them or two of them. You really have to have all three, and they're nested together. So if you have all these three things present, even though you're surviving something terrible, the chances are you're going to do much better than if you don't have these things present. So we think about capabilities, the sphere of capabilities. This is referring to individual capabilities that kids or adults have. It could be the sense of self-efficacy. I'm here, I can do something. I can be the best speller in my class. I am the best football player. A sense of being able to make choices in their life. That's that self-efficacy piece. Having other kinds of skills. One of the reasons why we're in schools right now with the CAC is because we're trying to get kids who've been impacted by trauma in schools where we have really good access to them. And we're doing skills groups with them. We're teaching them breath work. We're teaching them meditation. We're doing movement with them. We're bringing in yoga because we understand that kids have to have their own sort of toolkit with them, just as we, the adults who work with them, need to have a toolkit. The second sphere is probably, well, it is, I'm not going to say probably, the second sphere is actually the most important sphere when you talk about being resilient after trauma, and that is the sphere of attachment and belonging. And here, we're not just talking about having a big family or having a lot of people who love you. It's really about a child having access to a competent and caring adult, a person who is trauma-informed, a person who understands that the very challenging behavior that the child might have is actually the way this child is adapting and surviving. So really looking at the child through that non-judgmental lens. And then finally, the third sphere is community, culture, and spirituality. So you remember earlier I talked about how you got to bring in the culture, you've got to honor community, and you've even got to honor people's spirituality. That is such an important part of healing and recovery. So it's not about really preaching to people or, quoting the Bible to people or anything like that. It's really about asking them what are their faith practices, what are they using, and helping and encouraging people to continue to do that because we know it gives them a better shot. And I kind of just summarized these already. So what we're basically talking about, again, is we're shifting the paradigm to being trauma-informed. Being trauma-informed really is, it goes hand in hand with all the things I've already summarized about what trauma is about, really having an understanding of trauma, really looking at, if you're an educator, for example, that teaching a child about math is equally important to having a relationship with the child in the classroom. And I should say that in reverse order, that if you're a teacher and you're trauma-informed, what you understand is that having a rapport with your student and having a relationship with your student is really the first step. And bringing those social and emotional skills in the classroom, understanding that many kids are coming to the classroom with their executive functioning offline. They can't learn, their brains are offline. That before you're going to teach them math, you have to have that relationship, and you have to have things right there in the classroom that they can learn to calm their nervous system. Really important. Those things are not separate anymore. They need to all be a part of the process. And it's the same concept for hospitals. A hospital can be trauma-informed or not trauma-informed. We recently worked, and we're actually going in for a second round of training with an entire hospital system through the Center for Mind-Body Medicine in Indianapolis. The Eskenazi health system hired us to come in and train everybody, not just the nurses, not just the physicians, but also the cafeteria workers. The CEO is in the same training group with the people who work in the cafeteria. And they're understanding our skills, and they're getting the science of trauma and stress so that everyone in the system is speaking the same language. And they're understanding what we just talked about how important that relationship is with patients. That if they're really going to make a long-term difference with their patients, that it's got to be holistic. So it's really interesting to see entire systems becoming more trauma-informed. Just included some other factors. I mentioned those three spheres that are associated with resilience. This is what SAMHSA says is associated with resilience as well. And when you look at this, I would invite you to look at it through the lens of a system. Some of these things you've already heard me talk about, finding meaning, relationship, but how important access to mental health resources are, connection to a school. I think I illustrated that when I talked about the minute children weren't connected to a school, we saw child abuse go up. I mean, that is a very concrete example of how important connection to school is, and having an environment that they can be in that is safe, engaging, and supportive. Here's a little summary that you can read about later about what it really means to be trauma informed. I've really talked about a lot of these. One of the important things is avoiding re-traumatization. When I went to Stoneman Douglas High School with our team there, some of our teachers who had actually witnessed their students and colleagues murdered, unfortunately had to go back to those classrooms the following year. And when they went back, what they saw was that, you know, they had changed everything in the building, and they had created like a fortress. They had doors that were locked, like had these fancy locks on them, but the walls, I don't think I have any pictures with me in this presentation, but I have pictures of things that they had on the walls in the classrooms that the teacher showed us, things like, here's a bleeding kit. So they had a bleeding kit on the wall mounted right next to a desk where a student is sitting to be learning. Or there were little emblems in the corner that designated that corner for during the active shooter drills. This is the corner you go to because this is the corner that the shooter can't see if they're looking through the window. And so the kids would all go there. So when we were there, they were actually having active shooter drills while we were there working with the students. And the students immediately got up, they went to that corner. But what we did was we used that time that we sat quietly, and we used breathing because we knew that the kids were in fight or flight. How could they not be? This was a trigger to the previous trauma. And the teachers began to really advocate for even the physical environment of the classrooms to be less re-traumatizing for their students and for themselves. And in summary, being trauma informed means that you're changing your question. And I think, you know, one of the most important things for hospitals, for doctors' offices, to really understand that when you're doing your assessment of people and you're going through that whole list of your psychosocial questions, that you need to include the question, what happened to you? It's not just about what's wrong with you. We're changing the whole conversation to what might have happened to you, because we know it's common. If we think that 80% of people may have experienced trauma, then we need to change the way that we assess, and we need to include those questions that rule out traumatic events. That was a picture of a kid in Plaquemine Parish who was checking in. I mentioned earlier that not all kids are verbal when they've had trauma, and this was after the oil spill, and this child was using a feeling mask to show how he was feeling because he couldn't really put it into words. So there's a lot of different creative ways to do that. And here's a slide that I love that is a summary slide of comparing the difference between what it means to be non-trauma informed as opposed to trauma informed. So when I'm working with a room where I'm not in a pandemic and there's a room full of people in front of me, I'll say, you know, what stands out to you? Which ones are the ones that really stand out to you? Because the one on your left, that's the old school way of doing it. And the one in the blue on your right, that's the new school way of doing it. And people will often say, they'll often point out like the one that says here on the orange side, you're crazy. And then if you follow that line all the way across to the blue side, it says, it makes sense. So being trauma informed says the behavior in front of me might be a little crazy. You know, the child is standing on the desk and clowning in the middle of class, and that's really crazy. Or maybe I'm in a group with a bunch of folks that are adults, and some of them are on something, and some of the behavior might be crazy. But when I really look at the root of the behavior, I may find that those crazy behaviors, quote unquote, have their origin in the way that they adapted to trauma. So the kid who's dancing on the desk may have learned to be the clown in order to deflect violence in the family from dad to mom. As long as I can clown, maybe dad won't hit mom. So it's really important to look beneath those behaviors, but that's just one example. I'm almost done. When I think about being trauma informed, this is just the little continuum that I developed to make sense of it for myself. When you look at the right side, you'll see this is where all of our formal mental health treatments live. That's like psychiatry and medicine and psychotherapy. And on the left side is what we call trauma-informed care. So when you think about responding to trauma, you want to start on the left side. The left side is really everybody. If we're going to become more progressive in how we respond and transform trauma, we recognize that everyone has to be in the conversation. Everyone has to have the opportunity to have the knowledge, and we all are trauma informed. So in a sense, that left side could be a bus driver. And the bus driver who's trauma informed, or the school resource officer, the sheriff's officer that is stationed at a school, if they're trauma informed, they're probably very likely to know how to de-escalate a situation before it becomes bad. Maybe a person doesn't need formal psychotherapy, but they need a very good and positive relationship, mentor, role model. And then as we move forward across this line from left to right, then our interventions become more and more specific as people indicate that they need more. So in schools, for example, we may have children who are living in chronic stress environments, chronically stressful environments, or they've experienced trauma, but actually they may just benefit from a group and they may not need much more than that. So it's really looking at the former mental health treatments being reserved for the people who really need those formal mental health treatments, but that really responding to trauma is a much larger circle of care. So that's the end of my slides. And wow, I think we actually have about 9 minutes to consider questions if there's any from anyone. Any comments, any questions, including questions about application for specific places where you're working and encountering trauma? I'm happy to share kind of some ideas about that. I'm sorry.
The first one is just a comment. It says, very informative. I just had an experienced trauma and used some of your pointers. And we do have one question. How could I get more info about your hospital system training?
Okay. I'm glad you asked that question because it reminds me to give you this resource. So you can go to the website for the Center for Mind Body Medicine. That is cmbm.org, cmbm.org. And there are tons of resources on there for actually all the viewers. If you don't have the chance to go through our entire training program, there are lots of videos and skills of meditation and guided imagery and so forth that you can actually download and practice. The Eskenazi program is the program that you'd be looking to click on that website. We did 2 rounds with Eskenazi 2 years ago, and we're actually coming back again for a second round. I would also, I don't think it's too premature to let you know that finally, after many years of working toward this and having dialogue, it looks like Baton Rouge may be getting its own mind-body training, like we've seen in other places in the United States and around the world. We have a group of very progressive people here and funders here who are looking to and planning to bring a full community-wide training to Baton Rouge across many different disciplines. The idea is that Baton Rouge would then have its own leadership team so that we could train our own folks, as many as we need to train in mind-body medicine, whether it's in hospitals, law enforcement agencies. So we're hoping in 2021 that we will get the same thing that we've seen in Broward County, Sonoma, Portland, Seattle, DC, all of those, Minnesota, all of those places. There's a movement toward that right now.
So we have another comment and a question. The first comment says, no question means your presentation was extremely clear and informative.
If not speedy. Thank you very much.
And the next question is, are there some general tips to keep in mind to promote mental health and resilience in youth?
In youth, well, I think I've covered some of them, but I'll definitely highlight them. I had a conversation with an intern this morning before I came here, and we were talking about, we were reflecting back. I remember being an intern, and I would share with you the same thing that I would share with an intern who's really just new to this work with young people. Never underestimate the power of a relationship. Never underestimate whether you have a lot of skills or a lot of tools or a lot of knowledge. All that stuff is important, but the real thing is when you bring your heart to a relationship with a kid and you're present and non-judgmental, accepting, and willing to look beyond whatever is on the surface, and you yourself, with your own awareness, you have the comfort of using your own authentic self. Be able to be vulnerable. That really is probably the most commonly given advice that I give to people, and to never underestimate the power of that, because those are things we can't teach. We can teach people curriculum, we can teach them therapeutic modalities, but honestly, if you don't have that willingness to be vulnerable in an appropriate way and to really listen and be present for kids, then all of that kind of goes out the window.
All right, we have another comment that says, awesome. This is from Bridget Webster. Awesome. I have been very interested in receiving the mind-body training. Thanks for your perseverance with this.
You're welcome, Bridget, and I hope you'll be the first one to sign up. Appreciate your support. It's finally happening. Anything else?
If there are any other questions, remember you could ask in your Q&A box. We have 4 more minutes. Jamie Barney says, great information, eager for this to be understood by all so that it can be better implemented into our systems. When staff are overwhelmed with requirements on data collection, data entry, and dissemination of specific information on a schedule, it makes it very difficult to take the time to understand the cause of behaviors and get people help. Thank you.
You're absolutely right, and that is such an important, heartfelt thought that I go and I talk to teachers that they're really having to juggle so many mandates and priorities and benchmarks. But honestly, I feel like if you take the time, especially in the beginning, and you set the stage, you set what we call the container in your classroom to deal with these other needed skills for kids, it's actually going to make the other stuff much easier. And I also want to mention, I'm glad we're talking a little bit about schools, because I want people here who are local listening to know that the Baton Rouge Children's Advocacy Center, we have a project now, we have a contract with EBR schools that we've always worked in schools, but this new contract allows us to go in and do these mind-body skills groups with children who are at risk, who may have had trauma or chronic stress, while simultaneously doing professional development with teachers in kind of taking a deeper dive in what you've heard me talk about today. So we're working both with the teachers and with the students in local schools. But as you know, we may have the contract, but we actually need help getting in the school. So if you know of a school or a leader that might be interested in talking to us about having the program in the school, we're actually capable of doing things virtually as much as possible. Give us a call at 225-343-1984, and we'd love to come out and have a conversation about it.
I'm going to combine these next 2 questions.
Okay.
They wanted you to repeat the mind-body training, please, but the other one, it says, will the future training be announced on the website? And definitely looking forward to it. I think that response will answer both.
So the unfolding of the community-wide training, it's going to be a big deal. There'll be a massive publicity about it when it actually unfolds. We are actually planning to, starting from now to the end of this year and the early part of next year, to begin some workshop series in the community to begin to just introduce what it's about to people. So there'll be lots of opportunities even before the big training to kind of learn more about how to get involved. And then there will be offerings sometime next year. We're kind of looking to see what happens with the pandemic. to see how we're going to unfold the training. We can do it virtually or in person, but many of us prefer the in person if possible, but all of that remains to be seen. But we're really hoping for next year.
Okay, we just have 1 more minute, so I'm going to ask one question, and hopefully the rest I can share with her. Maybe we could get you a response back. But the next one is trauma training mandatory for foster parents or already in place?
I've worked a lot we work a lot every day with DCFS. I don't know if it's actually mandatory. I know that training is mandatory in general, and I know that there are a lot of offerings that I've seen and have been asked to do related to trauma, so I think it's pretty high on the priority list for foster parents and understanding trauma. The website that someone asked about, someone asked to repeat the resource about mind-body medicine. It is cmbm.org. You can go on the website and see how we've trained in other communities. And Dr. Jose Calderon, one of your plenary speakers, I think was here earlier. He's also a local faculty, along with myself, in mind-body medicine. So he probably has, his talk was on mind-body medicine, so you could also refer back to his presentation for more information.
Let me see, I think it's probably going to shut us off because it's time limited. If they will leave the questions up, I'll try to get a response back. Maybe we could do that. Is that possible? All right, so you can say bye.
Thank you, everybody. Appreciate your attention and your support. And I'll be glad to talk to anybody anytime. If you have questions that we didn't get to today, feel free to reach out to me via my email address, which is Toni, that's Toni, at Baton Rouge, spelled out, CAC.org. And we'll respond to your questions that we didn't get to today. Thank you so much.